We have Dr. Kalpana Manthiram, who is actually at the National Institute of Health, which is the facility in terms of research and everything that they've been doing. And Dr. Kalpana Manthiram has actually worked, knows the most amount of AP families here because she's been studying trisomy AP and duplication AP families for the past 3 years. She's already written an abstract that will be published very soon, but her interest here is overall working with the AP community, getting to know all of the AP heroes really well. And why this is important for each of us here is because what she's focused on, all of her work, is how, what inflammation and immunity markers that she's looking at, fevers, ulcers, and why that's relevant, how to manage that, and kind of find links to even kind of forward-looking precancerous genes. And I know that sounds really scary, but she's brilliant in the work that she's been doing, so we're really fortunate to actually have met her before Project AP started, that she was already working with AP Heroes. So again, she will talk a little bit more about what she's been doing and how she's very eager to continue understanding from each of us all of the things that we're experiencing with our children.
Thank you, Bina, and thank you so much for having me here. It's truly been an incredible and moving experience meeting so many of you, and it's really motivating to us as researchers and physicians to hear your stories and to see where our research will take us to. So as Bina said, I'm a physician and researcher. I'm at the National Institutes of Health. I'm in Dr. Dan Kastner's lab. I'm actually a pediatric infectious disease doctor, but I study things that are not infections. I study immunologic and inflammatory disorders. And I just wanted to note that pretty much all of this work was really driven by the observations of families. They noticed things and told me about them and said that, well, a lot of other people with similar conditions are saying the same thing, and that really drove our work. So really count on you to let me know the things that you notice. So today I'll be talking primarily about patients with trisomy 8 mosaicism, but I've also talked to several AP families, some of who are in this room, and one of my dear patients is here in the back. So I will tell you about those patients and how they may overlap with some of the symptoms that children with AP duplications have. Like I said, I study patients who have periodic fevers. So what is a periodic fever? So these are syndromes in which children have recurrent attacks of inflammation, and those attacks can include fever, or they can include other symptoms outside in other systems. So they may have their GI system involved and have ulcers or have abdominal pain. They may have their lymph nodes involved. They may have their skin involved and have rashes. And usually they have these episodes where they're inflamed and then they're fine in between. So they're sort of attacks of inflammation. And one important thing about these episodes is that they're stereotypical. So that's sort of an important feature. So if your child has had recurrent episodes of fever or some of these other symptoms, and they all seem the same to you, that's an indication that this could be some type of periodic fever syndrome. And these are not due to infections, but they may have been diagnosed as infection, because usually when you see a doctor, most people who come in with a fever have an infection. So when you're evaluated, they may say it's a viral infection, or the eardrum may be a little bit red, so your doctor might call it an ear infection. But if you're feeling like that it's sort of subtle findings of an infection, or it's the same thing over and over, it may indicate a periodic fever syndrome and not a true infection, and needs to be evaluated from sort of an inflammation instead of immunologic point of view. So there are a lot of white blood cells, different types of white blood cells in our body. So there are two arms of the immune system. So the first arm is called the innate immune system, and this is sort of our first line of defense. So right after your body encounters some type of bacteria or pathogen, these innate immune cells go into action and start fighting it. And they're not really that specific to the bacteria or virus or whatever it is, but they're right there ready to go and go on the attack. as opposed to the adaptive immune system, which takes a little bit longer to develop, but it's really honed in on that particular bacteria or virus or whatever the pathogen is. And the reason why I bring that up is because the periodic fever syndromes that we study are caused by problems in the innate immune system, that first line of defense. And those diseases are called autoinflammatory diseases, and that's different from autoimmune diseases, which I bet most of you have heard about. And autoinflammatory is a different type of disease process that also leads to attacks of inflammation, but it involves a different arm of the immune system. And some examples of autoinflammatory diseases are familial Mediterranean fever or PFAPA. That's the most common periodic fever syndrome. Maybe and some of your kids might have been diagnosed with that, but I think patients with chromosome 8 duplication sort of have a unique inflammatory disease. So that, like I said, autoinflammatory is sort of different from autoimmune, and autoimmune diseases are like rheumatoid arthritis, lupus, Hashimoto's thyroiditis. So sort of different parts of the immune system at work, but they might have some overlap in some patients. So most of your children and the 8P heroes here have a duplication on part of their 8th chromosome that might be associated also with areas of deletion and inversion. And in most of the children here, all of their cells have this chromosomal abnormality, but in some it may be mosaic in that just a portion of the cells have it. So that's in contrast to trisomy 8 mosaicism, which are the biggest chunk of patients that I've started following, but I think hopefully with your help we can start looking at patients with 8P duplications as well. So in trisomy 8 mosaicism, the entire 8th chromosome is duplicated, so that's different from most of the children here. So this is the karyotype. There's 2 copies of all the other chromosomes, like as is normal, but for chromosome 8, there are 3 copies here. But it's not 3 copies in all the cells, so they're mosaics. That means that the 3 copies are only in a portion of the cells. So in this case, I think there's 7 cells here, and 4 of them have trisomy and 3 of them do not. So full trisomy 8 is not considered to be compatible with life. I don't know of any patients who have full trisomy 8, so all of the patients we follow are mosaic. And the mosaicism can vary by tissue type. So in the way the tissues form from the embryologic state, there's different lines that they can take. And so it may be that the portion of the cells in a certain tissue type have a lot of mosaicism, but in a different tissue type, very few cells are mosaic. And I'll get to why that's important later, because there might be certain cells that are more likely to be mosaic. So not to complicate things more, but there's also 2 types of trisomy 8 mosaicism. And I bring this up because, most patients, if you look up trisomy 8 mosaicism, actually have like pushing buttons here, okay, have acquired trisomy 8 mosaicism, and those are adults. So these are adults actually with cancerous syndromes. So those are including myelodysplasia and myeloid leukemias, and they develop because of problems in their bone marrow. They get trisomy 8 mosaicism and then develop cancer. And usually that's only confined to white blood cells of the innate immune system or myeloid lineage. That's different from most of the patients I'm studying who have what's called constitutional trisomy 8 mosaicism. So they have trisomy 8 from when they're born, and it affects multiple cell types, not just these specific white blood cells. But this association with cancer is interesting and something that we need to consider also in the 8P population. I'll tell you what we found in these patients with constitutional trisomy 8 mosaicism. So trisomy 8 mosaicism is thought to affect 1 in every 25 to 50,000 births, but I think it's probably more common than we think. Just some people don't get genetic testing, so they don't realize that they have it, especially if they have very low levels of mosaicism and not as many of their cells are affected. It's also called Warkini syndrome, and most patients also have some developmental delay or some type of abnormalities in the development of their organs. And interestingly, even before we started, this is why we even got started, that there have been a few case reports of patients who have trisomy 8 mosaicism and have inflammatory symptoms. And then we started getting several referrals of patients who actually people thought they had some other inflammatory disease, but then we realized it's probably its own distinct entity, that having 3 copies of that 8th chromosome leads to these inflammatory symptoms. So what we tried to do is characterize what these patients' clinical features are, what inflammatory profiles they have, and what their treatment responses are. And I'm going to share those with you so we can see what the overlap might be in some of your children as well. And then I'll go into some of the data I have about patients with 8p duplications. And I heard from many of you yesterday, and it sounds like many of your children may also have similar symptoms. And sorry, I forgot to mention, we think having that 3rd copy, the triplicate of genes from trisomy 8 leads to a distinct inflammatory disorder that we're calling trisomy 8 associated autoinflammatory disorder, or abbreviating it as triad. So these are the faces of the 7 patients I follow at NIH with trisomy 8 mosaicism. They all look a little bit different from each other even, but they do have some features, like a lot of them have kind of rounded noses. They might have, I can't see here, but some of them have some drooping of their eyelids, but they can have various degrees of differences in how their faces look, depending probably on their degree of mosaicism. So the patients that we have followed have ranged from anywhere from 3 to 37 years. They have a varying percentage of mosaicism, which we usually check from their blood. And 84% of them had some type of developmental delay, but one patient was actually completely normal in her development. These are the main features that these patients had. So those included problems in their fingers. So these are some pictures of what their fingers might look like. A lot of them also had misalignment of their eyes or strabismus. Some had hydronephrosis, agenesis of the corpus callosum, vertebral defects, and inguinal hernia. So from hearing yesterday what Dr. Chung was talking about, I think there's some overlap with the features that many of your children also have. So this, again, there are pictures of some of those, some of the finger deformities that these patients had. So then getting to the meat of what I study, which is the inflammatory features. So we found in that group of patients that 85% had these recurrent stereotypical fever episodes, and I'll tell you a little bit more about what they looked like in a second. Most patients had these severe oral ulcers, so you can see in these pictures. So these are ulcers that aren't just run-of-the-mill canker sores, although I think more patients with 8p might have canker sores than what the general population has. But a lot of these patients had really severe ulcers, so they're more than a centimeter in size, last over a week. They're very painful, usually in the mouth. So here's some pictures. And then others have ulcers even in other parts of their GI or groin, in their groin area. So about half had ulcers somewhere else. And you sort of have to be careful and get a close history to find if they have symptoms that prompt you to look for ulcers elsewhere. Also, about half had rashes. So these rashes were usually like pimples or acne-like rashes that are probably part of the inflammatory process. And then one patient had inflammation in their eye, which is important to watch for in patients with these types of inflammatory disorders. So this is a little bit more about their periodic fevers. So just so that you know what they sort of look like and think about if your child might have something similar to this. Like I said, a lot of patients just don't even think of it as a entity, as something that needs to be could be looked into, that they just have been diagnosed as having recurrent infections in the past. So usually these patients started having fevers when they were about 2 years of age, but they can start anywhere from 6 months, 5 years of age, or even later. The episodes last anywhere from 2 days to 14 days, and they're pretty irregular. They sort of just show up whenever, but some people will say it's sort of regular. And they can occur anywhere from 2 to 8 weeks. And during flares, patients, some have nothing, they just have fever, but some of them get ulcers, they get rashes, big lymph nodes in their neck, joint pain, abdominal pain. And another interesting thing is that many of these patients report that some things trigger their flares. So if they got a vaccine soon after they get a flare, or they got some other true infection and then they get a flare afterwards, or some stress like they traveled or had a birthday party or something like that can also trigger these episodes. So during a flare, one thing that would be helpful to get are labs if you suspect that your child might have some type of inflammatory disorder, because we would want to see some evidence of inflammation in their blood. You don't always see it, but it's a big clue that there might be some type of inflammatory disorder going on. So in our patients, we like to look at CRP. So that's an inflammatory protein made by the liver when the body's inflamed. And as you can see, they're actually pretty normal when they're not in the flare state. But when there's a fever episode, the CRP goes up. And the same thing with some of those innate immune white blood cells that I talked about. During a flare time, they go up, the neutrophils and monocytes. So getting blood work done during a flare can really give us more evidence that there's some type of inflammatory disorder going on and not something else. So what we do is we've been trying to see, well, what kind of inflammation is going on. So we take, we get a sample of blood from patients and look at what type of inflammatory genes are getting expressed. And when we did that, we found that patients with triad had high expression of these genes that are all linked to the innate immune system and activation of the innate immune system. And as I'll show later, we were able to, we targeted some medications toward these pathways, and a lot of these patients have had some improvement in their inflammatory symptoms. So another thing that we did is we took patients' blood and we sorted it. We can attach what they call antibodies that allow us to label the red blood cells with the white blood cells depending on their type with different colors, and then a machine sort of sorts them into different bins. And then, I looked at, how much trisomy 8 is in each cell type, thinking that, if a certain cell type has a lot of trisomy 8, maybe it's driving the process. And interestingly, we saw that the monocytes, which are a part of the innate immune system, had the highest percentage of the trisomy 8 cells compared to the lymphocytes. So again, sort of what I'm telling you is that these innate immune cells seem to be really activated in patients with trisomy 8 mosaicism. So these are the treatments that we've used in these patients. So we've tried steroids. Usually they need many days of steroids to sort of quell the fevers. But we sort of shy away from using steroids for a long period of time because long-term steroid use can have effects on the immune system, on bone mineralization, on metabolism. So if a patient's getting a lot of steroid, we try to steer away from that and try to use some of these other medicines. We've also been using colchicine. So that's actually a medicine some of you might have heard about. It's used in gout. It's also used in another fever syndrome called familial Mediterranean fever. And many of our patients who've taken it every day, it sort of prevents them from having flares. And then we tried other medications to sort of block the genes that seem to be upregulated. So these are really honed in special biologic medications that really pinpoint certain inflammatory proteins. And some of our patients have had improvement on that. And one patient had really severe ulcers throughout his GI tract, was not able to eat at all. And he actually underwent a stem cell transplant, a bone marrow transplant, and improved after that. So we think that, like I said, these activated innate immune cells are really driving the inflammation in these patients. So I wanted to note a few other features of these patients to see if maybe they may be important in patients with these patients with 8P abnormalities. So this sort of started from our patients too. So 2 patients reported sort of more than what you'd expect bleeding. So one of them actually had a pretty minor fall and had a bleed around her brain. And then another patient had very severe menstrual bleeding, and both of them had a deficiency in these granules that are in the platelets. So the platelets help the blood clot. And these granules are very important to help them sort of stick together and form a clot. And so they had abnormalities in that. And then one of those patients also had abnormalities in how the platelets develop in the bone marrow. So I don't know if this could also be a problem in the in among 8P heroes, but I think that's because there seems to be an issue in some of these trisomy 8 patients. I think it's worth just asking about and thinking about if it might be too, because if certain genes are in triplicate there or causing issues, maybe those are some of the genes that could be related here too. So yeah, let me know if any of your children have had issues with bleeding. So another question is there a link with 8P and myelodysplasia or myeloid leukemia? So myelodysplasia is a problem in the bone marrow where the cells don't develop normally, and it's also a precancerous state. So none of the patients with trisomy 8 I follow have developed MDS or leukemia, but there are several case reports in the literature of patients developing these cancerous syndromes, and it's not totally clear exactly what genes are involved in that. We have found even in these patients who don't have cancer, they sort of have skews in their cell populations that are seen in patients with cancer. I mean, they do not fit the criteria at all, but they have some abnormalities in the types of cells and also on their bone marrow, causing their cells to develop abnormally. That may be a risk factor, so we follow them very carefully for any signs that their blood counts might be dropping. I don't know of any children with 8P who have developed, or adults who have developed cancer, or even 8P being linked to leukemias or blood cell issues. But I think it would be important for us to sort of look at the different types of white blood cells that are in the blood of these patients to see if there's sort of risk factors or things that make them look like the trisomy 8 patients. And one other thing in the peripheral blood, this red blood cells tend to be big. I don't know if any of your children have that abnormality as well. So that would be interesting to look at how what type of blood cell development abnormalities there may be in these patients as well. So now turning to 8P duplication. So this question, well, do patients with chromosome 8P duplication also have a risk of having these inflammatory symptoms? Because both of these groups have extra copies of some of the genes on chromosome 8. I mean, trisomy 8 have the entire chromosome, so it's sort of slightly different, but there's still duplication of the P arm in those patients. So I've interviewed, actually some of you in this room too have contacted me, and we found that of the 24 patients with 8P duplications that I talked to, and they're sort of a heterogeneous bunch too, I haven't really categorized them by the different diagnoses, but I'll try to do that after being here at this conference. And 63% had some recurrent fever or ulcers. So it may be that the people who had that were who contacted me because they knew this is what I was looking at. So I don't know if this may be skewed, but of those patients, many had those recurrent fevers. About half had some type of mouth ulcers, and about 20% the mouth ulcers were severe. So they were bigger than a centimeter, or they were lasting for more than a week. And then several had ulcers outside of the mouth as well, and painful rashes. And one of my patients who's here started on anakinra at the start of her fever episode. She'd have fever and a rash on her skin, and as soon as she took one dose of anakinra, it would just melt away like within minutes or hours. And I think after starting it is when they actually realized that maybe when she was having these fevers, she was fatigued and tired. Like you sort of recognize that it's having more of an effect when you're able to make it go away, and you can might see, even though having these fevers alone may not have long-term consequences, it may affect the quality of life and ability of the child to go to therapy or just have energy to do their other activities. So I graphed the patients that I've talked to. So this is, hopefully it's not it's fairly easy to read. So these are the patients with chromosome 8 duplications that I spoke with, and I graphed. So in solid lines are areas of duplication that each patient had, and then these dotted lines are areas of deletion. So you can see I did not graph if they had an inversion, but you can at least see like a lot of these patients probably had 8p duplication, deletion, and likely inversion as well. So I wanted to see, well, is there sort of a common area that the patients who have symptoms have duplicated? So, and I wasn't exactly able to find that, but you can see that quite a few of the patients that I talked to with 8p duplication have these inflammatory symptoms. So red is just recurrent fever. So everyone who has these symptoms is up here, and anyone who didn't is down here. So quite a few of the patients that I had spoken to had these inflammatory features. There are also a few who had duplications on the Q arm who had these features. So they're not, as you can see, they're not overlapping. They have something different, or is there some other disease process that I'm not really sure, but at least there's been quite a few patients who have these P-arm duplications who seem to have these inflammatory features. I have looked at the genes that are on this arm. There's actually quite a few that are involved in inflammation, so we haven't yet looked at exactly which one of those may be playing an important role, but it might be helpful if others of you have these inflammatory symptoms, if you would be interested in our study, which I'll talk about shortly. It might be interesting. It might help us to really hone in on what genes might be driving the inflammation in these patients. So if you think that your child might have one of these inflammatory disorders or might have an autoinflammatory disorder, I think there's a few things that can be helpful. So we sort of have to rule out infection first and rule out other periodic fevers. But so it's really, the first part is gathering data. So there's some things that you can do to gather the data and make it speed up the diagnosis. So one thing that I really recommend is keeping a fever journal or symptom journal. So, and if you want, I have sort of a copy of one that I can email to you, and I'll give you my email address shortly, and you can fill it in. But or you can make your own. You can print out a calendar or make a chart and write the date, the temperature that you note, and try to just measure it the same way each time. Don't add any degrees or anything. Just measure it the same way each time. Note it on the calendar, and any other symptoms that you have, especially the ones that I sort of mentioned before: ulcers, big lymph nodes, rashes, joint pains, abdominal pain, changes in the stooling, vomiting. Those things note on your calendar. And then if you did any intervention, so even if it's Tylenol or Motrin, just note it down and see if it made any improvement, or antihistamine, anything that you tried. And then any testing, like if you took your child to the physician and they did strep testing or viral testing or whatever, just note that in the journal. I just want to note that sometimes like even strep testing is not always indicative of strep. Like if you go to a kindergarten class and just swab every kid, about 15 who doesn't have symptoms, 15% of them are going to be positive for strep. So just because they got diagnosed with strep based on the swab doesn't mean for sure that it's due to strep. If you really feel like they have the same thing over and over again, then that could be a sign of a periodic fever, and I'm happy to review the records with you and your child's story to see if that could be the case. Other a very helpful thing would be to have your child's physician examine them during a flare. So not all physicians are very used to looking at patients with periodic fever, but I would tell them to really look at these symptoms. So like try to get as close of a look in their mouth as you can. You might have to look a little bit closely at the inner surfaces. I know that's not always easy, but just as best of a look as you can would be helpful. Checking all the lymph nodes, the skin, and the belly and the joints are really helpful. So just I would just note that these symptoms are useful. And if you suspect it, I'm just, shoot me an email, and I'm happy to communicate with your doctor too, to let them know what to look for. And then one other useful thing, I know it's not always easy to do, but getting blood work done during a flare is helpful. Like I said, there's markers of inflammation that if we see those are very indicative of some type of periodic fever process. And so if you're able to get that done, that would also help us make the diagnosis. So some of the next things that we're doing, so I'd like to try to understand what patients with chromosome 8p duplications have. I think from what patients have told me, I mean, I'm not saying that all of you have it, but I think more than just what you'd expect in the general population have these types of recurrent fevers and may have bleeding problems and have these recurrent fevers. I haven't heard a lot of people describe these bleeding problems or problems with cell development, but it may be that we haven't looked at it. I mean, if any of you have that, please do let me know so that we can, see if it's similar to the other patients and see if there's, a group of patients who have that. And then we also would be interested to see, well, what specific genes on the 8th chromosome sort of drive this process, so then we could really hone treatments toward that. So these are all the people who help with this. Like I said, it's a big group of who help us understand what's going on with these patients. And in particular, the families, like I said, really drove a lot of this work because they noticed the commonalities in these observations. So please do let us know if you have immunologic and blood issues that you notice that we would be happy to look into them. So if you have any questions or you think your child has a periodic fever, you'd like to contact me, please feel free to email me. It's my email address. And then our nurse is Tina Romeo. She knows, she's been helping us follow most of these patients, so she will help sort of get your information together, and we can either if you have a lot of these inflammatory symptoms that seem like it would be helpful for you to come to NIH. Would be happy to see your child there. Or we also frequently work remotely with other physicians. I'm happy to talk to them. Or if you'd be interested in sending blood by FedEx, we can arrange for those things and send you the mailers and the boxes, everything prepaid, and with the tubes, if that would help too. So there's a lot of ways that we might be able to help, even if you can't come to Bethesda. And so I'll take, I don't know if there's time for questions, sorry.
Questions? Does anybody have any questions?
Did anybody with AP deletion have any of the symptoms?
I haven't noticed that degree of inflammation in the 8p deletion, but you'll have to tell me. I have, so most of I really focused on the duplication because it was so similar, more similar to trisomy 8. And my sense from talking to you is that it's not the same degree. Just from yesterday, the panels, I think there's something special with the duplication that's leading to these inflammatory symptoms. But if any of you who have children with 8p deletion have similar, then please let me know. But I don't think it's the same. I think the duplication is a little bit different.
Next question right over here.
Yes.
Mine's not as much a question, but I was just going to comment on the part where you were talking about the bleeding and stuff.
Yeah.
Because I know a lot of them aren't age appropriate yet. But we do depot shots.
Okay.
Once every 3 months, and that way we don't have any side effects.
Okay, so you may not know, right?
So that way, just an FYI.
Okay,
so
sure.
That way, because she doesn't deal with it.
Right.
Anyway.
Yeah.
Within that way, because she hasn't had one since she was like 13 and she's 25.
Okay. Got it. Yeah, they might not know.
We have time for one more question right over there.
Yes, I'm just wondering, my son is,
Thank you. It should be on.
Hello?
Is it working? Yeah, okay. So my son is as 8p 23.1 duplication and deletion.
Okay.
But he's 12 and I have not noticed any symptoms. Is this something that would start early in his life or that could appear later when in his teenage years?
That's a good question. Most of the patients I've talked to, like on average, the 8p families who have symptoms, the children start pretty early, usually by 5 years of age on average. So I would say most people start early, but not everybody. And sometimes it's in hindsight, and they're like, well, he had a lot of what they thought were strep infections or a lot of ear infections, but it wasn't like clear, like the doctor always wasn't totally sure. So sometimes in hindsight you can notice, but like I said, not everyone with 8p, not even everyone with trisomy 8 has these inflammatory symptoms. And I don't know why there's a difference. What kind of tips people off? Some patients with the same genetic makeup to have inflammation and others to not. I don't know. We don't know those factors yet.
And Are we still helpful to your research if we do not have any of the symptoms?
Yeah, I mean, I think as a control like to sort of compare, maybe there are even patients without symptoms, maybe sometimes they have low levels of inflammation that we can pick up on some of the gene expression testing. So that would be helpful to even compare with patients who do have the symptoms. So if you'd like to contribute, we'd be happy to get that.